we are going to move on relatively rapidly to our next panel. So, you guys want to come on up? So, there we go, Niraj. So, we've got Niraj Swamy, who's the CEO of CMefy, and his panel, who he will introduce for me.
Let's see. All right, we're going to give it a minute, maybe. Another 30 minutes of listening and talking and all that fun. You guys ready? This is about time, and this is about attention. This is about how we reward that, how we make it meaningful with two things that both of us are doing with our worlds. We're going to tell a bit about that story, work that team's doing in a beautiful way that his organization's leading. I'd love for you to introduce yourself. I've got some slides, but this is going to be a conversation. Listen, it's the afternoon. We're all ready to go home, make it meaningful. And that's where AI and what we're working on comes together. Team, thanks.
Thanks, Niraj. So my name is Hatim. I'm a GP in North West London. I'm coming on this from a health education in England point of view, where I lead our digital AI and robotics program in education. And I'm also a medical director for Kent Surrey Sussex Academic Health Science Network. So, I mean, look, we're in the context of ICSs. This is the National ICS Congress. This is an opportunity to start to think about how we might things do better in the future as we start to bring health and care together. And a big driver towards that is going to be the use of AI. The Topper Review in 2019 made it quite clear that AI is going to be one of the top technologies in impacting our workforce and changing the way we work in the future. And there's a big call in terms of the effect that AI will have in terms of giving us more time to care. And from a HE point of view, it's one of our key strategic drivers and kind of part of our mandate to, one, make things better for our workforce, two, make sure that our workforce is ready and agile and adaptable for a future digitally enabled system. And actually that's why some of the conversation today is going to be really helpful, because it's actually thinking about how do we capture things more effectively, how do we drive our learning more effectively, and how does that drive better patient care. But what I want to talk about briefly before we do that is just the role that impact that AI already has on the NHS that we know of, and the impact it might have in the future, and where we should focus some of our efforts in terms of planning from an integrated care system point of view. Defining AI. So, Topper Review defined AI as a broad field of science encompassing not only computer science, but psychology, philosophy, linguistics, and other areas. AI is concerned with getting computers to do tasks that normally would require human intelligence. Again, going to be really relevant when we talk briefly. So I'm not going to go through into the program, but the way we're doing this is we're doing horizon scanning, and this is what I'm going to be talking about today in terms of knowing what technologies are out there and how they're impacting the way we're working. We're trying to assess what people will need to know beforehand, and I've done a lot of work in terms of, I've had a lot of frustration in this space, that often with telemedicine, for example, we're asked to go and do video consulting and teleconsulting, but very little training and education to do that properly and effectively, and to know whether we're doing that safely for patient care, or when to pick a telephone consultation versus a video consultation versus a face-to-face consultation. And the final part is then creating the infrastructure to deliver some of that education and training, and actually really important to capture that education and training, because we all have as clinicians, we have appraisals. As non-clinicians, you have annual reviews, and these skills are going to be important to the way we work in the future, so we need to capture that training in an effective manner, because there's too much administration burden on the way we work. So we published with Unity Insights the AI roadmap in January of this year, and basically it's an idea of kind of what technologies are out there, the taxonomies and the spreads that they sit within, and the workforce impact of these technologies. So how we did this? Well, we looked at various databases. So we looked at the NHS State of the Nation AI survey, which was being put out every year for companies to say, we're developing an AI technology. We looked at the NIHR Horizon Scan, which gives us an overview of technologies and research and development in that space. And we looked at other areas like the Manchester Innovation Pipeline as well. We brought all of these databases together, and then we started to determine what the taxonomy of those technologies are. And what I mean by taxonomy, I'll explain in a second. And then we started to look at workforce impact. Does it impact primary care? Does it impact secondary care? And therefore, does it impact GPs? Does it impact cardiologists, et cetera, et cetera? And we created a dashboard with some case studies and a report that then goes out to the system, allows us to have conversations with the colleges, for example. And I'll give you an idea at the end of an outcome as a result of the AI roadmap. So, unsurprisingly, 34% of the technologies that we found in the system, of which there was about 246, were diagnostic. And actually going around the room today, I'm sure you see that as you see some of the stands and you think about the AI technologies that they're using, majority are playing in that diagnostics place. I had a really lovely conversation with the team at Skin Analytics, that, one of the companies that we've been supporting at Kent Surrey Sussex AHSN, who are a diagnostic technology for skin cancer, that have had their own challenges along the way, but we know this is clearly a space that needs development and clearly a space that needs investment on. And it's probably the place to start when NHS and then integrated care systems start to tackle this issue, because we know there are huge elective care backlogs, there are huge backlogs in our cancer waiting list as well. And so one of the ways we can filter this, and what I found really great from an NHS policy that we put through recently, was that GPs can now, or will soon, be able to directly put in requests for MRI scans, ultrasound scans, CT scans. And I work in a practice that's on the on the border of Harrow and Hillingdon. If my practice was 10 miles up north, we would be able to do direct MRI scans. Thing is, my practice is in Hillingdon, we can't request MRI scans. That is a sort of health inequity that we're creating currently in the system, and therefore if we think about actually how we can take away that health inequity, improve access to imaging. But if we're going to improve access to imaging, we need faster turnarounds in terms of the diagnostics that come out of that imaging. Automation service efficiency, we had a lot of conversation within the HE workshop this morning around if you tackle your efforts at sorting out simple administrative tasks. On a Friday, I'm a GP in a practice, and I'm spending lots of time trying to sort out my letters that come through on my DocMan that I have to review, my prescriptions. I get multiple tasks that get sent to me from reception. I've got a list of patients, often 25, 30 patients in the afternoon that I need to speak to. How do I realistically manage all this? We've got to think about where we can take some of that challenge away, take some of that pressure away, and automation can do that. And particularly not just for our clinical staff, but our non-clinical staff, our administrative staff. But the key areas that I think are really interesting from an ICS point of view are P4 medicine and remote monitoring. So P4 medicine is population-based, personalized, preventative technologies. And that's a really fascinating space because that allows us to work at population health level, understand challenges, and create personalized solutions to people. And when I was walking around, I got collared by the Giant team to listen to some of the medical students talking about some solutions that they're kind of exploring and working on, and they were talking about one of theirs was called diabetes, but diabetes, lovely. And actually, it was talking about how you could measure glucose levels along the way, and then that could help. You can identify what kind of triggers spike your glucose levels, and it's all a really nice idea of how you could kind of give it to the patient to be able to manage their self-care to a certain level, and then build in some clinician support along the way. And the remote monitoring is in the same way, I think, has been the way we've moved a lot of our care as a result of the pandemic. So, majority of these 246 technologies that we found in our Horizon scan are actually due to be deployed within the next 5 years, and a significant amount are already being deployed either now or within the next year. And this was done in January, so this will have moved along from when we did this piece of research. So, when we talked about in Topol Review in 2019, AI affecting the healthcare workforce maybe within about 15 or 20 years, actually it's going to be far sooner than that, and that's important to recognize. The types of workforce groups that we found are going to be most likely to be affected by AI. Again, probably not unsurprising to see radiology at the top of that and radiographer to be quite far up that. General practice at number 2 and non-clinical admin at number 3 I think is really interesting as well. Multiple roles affected is quite interesting because it means that actually these are kind of technologies are going to affect the multidisciplinary healthcare team. And also, what I would caveat this data is saying this is going to once we collected this data, a lot of this data is self-reported by the people that are working on these technologies, and therefore there's an inherent bias there because when you're promoting a technology, you tend to promote it in terms of the impact it's going to have on a doctor, perhaps because they're the most expensive part of our workforce. But actually, if you were to break this down and think about general practice as a whole, if there's a technology that's impacting general practice, it's going to be impacting not just the doctor, but the receptionist, the physician associate, the practice nurse, the whole team within that practice structure. And therefore, actually, if we went and did a deeper dive into this, you'd find that the impact on workforce is far greater, and therefore we need to do more to prepare the whole multidisciplinary workforce as a whole. ICS maturity is really interesting, right? Because as some of these ICS form, and within my role at Kent Surrey Sussex, we're working quite closely with Sussex ICS, for example, to develop their shared care record. And we're doing a lot of work with Kent and Medway around tackling primary care reform. We're doing some work with Surrey Heartlands ICS around their kind of vision for the population health and data management. And so as we kind of develop some of these programs, and ICS are kind of at different places in their journey, this was really useful for us to kind of map out what exists and kind of where it maps to the ICSs. And so yes, while we haven't directly done that, you can see on the dashboard where a lot of these technologies exist, and therefore you can quickly then look at where within the system in terms of ICSs is there more maturity in this space. And this could be really helpful for an innovator to say, where do I need to go to have conversations? It can be very useful for us as healthcare leaders to say, you know, where do we need to do a little bit more work? And then in Sussex, we're doing a whole piece around a digital boards program, a digital leadership program to help upskill the CIOs and the CCIOs in the region, because clinical leadership, non-clinical leadership is going to be key to unlocking this challenge. I also wanted to point out this is a kind of a collaborative piece nationally. So we've been working with NHS England at the AI Lab, we've been working with NICE and MHRA, and I think it's really important that we do all come together for this type of work, because actually, if we don't tackle this all together as a system, think about the policy issues, the regulation issues, think about the kind of validation that we need to put in place, and actually the investment that needs to go in that to support ICSs to do this properly and correctly, then we're not going to achieve where we want to go. So that's kind of a whistle-stop tour of kind of where we're heading from a HE point of view, and also nationally across HE and NHS AI Lab now, and MHRA and NICE. And also where we're trying to work with the system and the ICSs themselves to support them to become more population health mature, because that's one of their key mandates, and to use data-driven healthcare to achieve that. And if anyone here is from an ICS in the audience and wants to kind of explore that further, more than happy to have a conversation, because we've got various programs that can help support. I'm going to pass it over to Niraj now to give a bit of an overview on CMefy. But before I do that, I just want to say we've got to bring the workforce with us. And so we need to understand what the workforce need to know. We need to understand the capabilities. And therefore, we've done some work with University of Manchester where we've identified those key areas, those key capabilities. And therefore, we hope that we can build an AI-ready workforce in the future. And maybe CMefy can help with that.
Absolutely can.
If you want to reach out, please do. I'm more than happy to have a conversation.
Okay, we're going to switch our slides maybe to the CMefy packet, because this is going to get a little bit more relevant to why we're here. So you probably hear it in my accent. Not a UK-based person, also not a physician, but come from a family of physicians. And our journey with AI was all about looking at the provider, the practitioner, and saying, how can we simplify their life? And when Hatim and I first spoke, we're looking at this automation layer. There's an admin overhead that practitioners have. So take a step back, right? Like, look at how we all learn. This 30-minute talk, you're going to have thoughts about things that relate to your work. And things that relate to your work trigger reflections. Reflections that you capture that become learning that should give you credit. That's not how the real world works. You have to wait till some point later in the year to recollect what you did all year long, to then make a story and report that up. And as a practitioner, that's additional overhead. We looked at that very simple problem. We've looked at that as a company. We've built a solution that's really serving how clinicians learn in the workplace today. It's not always in a 30-minute, 1-hour, 6-day conference sessions. It's actually through what's happening in their day-to-day. And if we allow them to capture what they're doing in those moments and connect the dots to their practice, we can use AI to give them credit. In the States, this is CME. In the UK, it's CPD. And that's essentially what we've done. We've looked at ways to bring in technology that allows you to connect a key learning concept, not content, but concepts. Because you all, I know you guys are here, everybody's here listening to this wonderful talk that we're giving, but you're going to walk over with concepts. You're not going to remember the slides. You're definitely not paying attention the full 30 minutes. It's something triggers something that connects the dots in your heads, that makes you think about learning and your work, and you draw those connections. That's where AI can fill in the gap. One of the great things that you, Hatim, you've said about the work you're doing and leading is around automation and reducing that cognitive burden. Practitioners need to practice. And for that, they need support to really take over that cognitive overhead. Connect concepts to meaningful things that matter to you, and use technology like ours to really connect the dots and give you meaning. And the more meaning you make, the more credits you get. And you don't have to wait till one magical day in March to really submit all those things up to your portfolios, the way the system works here. So that's really been the story of what we've been doing. Those reflections don't just come back to you as an individual to give you that learning journal, that journey of how you've learned over the year. You can text them, you can call in a number and leave them. That's where AI works really well. It's kind of serving as an invisible entity behind the scenes. But most importantly, it creates a language of communication between the learner and the system. So the more HE is doing work with learners and their learner population, you really are able to make sense of what they're saying and how that reflection, how that learning is becoming action. So when Hatim and I started speaking about what this panel is going to be about and how we really intersect our worlds and what we're trying to do with this technology that has been in the US, supporting our provider network there, is looking at the UK world, the context here. How is the NHS supporting its workforce? It comes down to the workforce. The key words that you said, the phrases that really stick with me is about the workforce. There's 4 of them in my family, and this is very personal. You see what happens at dinner, you see what happens on Saturday mornings, you see what happens before they go to work, when they're WhatsApping their colleagues, what's happening when they're really jumping on a Zoom call. It's not about time, it's about attention. And that's where really we've thought about using AI, and we've implemented technologies like AI, data science, machine learning, and built an experience that automates something that otherwise would be very, very cumbersome. And that's what I really want to learn about. So we're going to switch this into a little bit of a conversation. I'd love to maybe pass it back to you, Hatim, and have us, me, and my team, learn a little bit about some of your challenges. And I do want to preface, one of the first things that we talked about is you have a general practitioner who's working with tech, right? This is a really unique situation. When you have been somebody that actually practices, you know what it is like. So maybe tell us a little bit about the challenges that you face where you personally have leaned on AI.
So while you're talking, I was reflecting on something. Every Friday when I get into my clinic, I open up my portfolio, thinking today's going to be the day where I'm going to put in a reflection. And I'm going to log that on my portfolio, and I'm going to get one step closer towards my appraisal in April or March or whenever it will be. And then at 7 o'clock, 7:30, I've got to the end of the day. I haven't gone back on that web page. I haven't reflected, and I've still got maybe about 20 letters to look at, or a certain amount of blood results to look at before I leave, just to make sure no one's in danger and just to tie things up. And that is the reality of general practice at the moment in the UK. And so whilst in an ideal world as healthcare professionals, we'd like to do what is good practice and capture our learning effectively, the reality is there becomes a mad dash, and some of you in the room will understand this, just before your appraisal to populate your portfolio. And that really isn't good practice. So there is an element, I think, as we start to think about integrated care systems, and we start to think about how we're going to support our workforce within those systems, and we also think about workforce well-being. So a few years ago, I worked as part of the Staff and Learners Mental Health and Wellbeing Commission that was commissioned by a previous Secretary of State, Jeremy Hunt, and to look at how the NHS was doing in terms of managing mental health and of staff and also learners in the NHS. And we made a series of recommendations to try and improve that. I'd like to say we have improved it, but I was reading last week around Birmingham Hospital Trust and some of the challenges they've had around their workforce and some of the things that are coming out from the workforce there in terms of how they're not being well supported. And as well as, unfortunately, people are still losing their lives over work. And therefore, it's clearly a challenge that we need to overcome. And so when I think of it from an ICS point of view, a key part of a successful integrated care system is going to be a happy workforce, and it's going to be people that have good mental health and physical health well-being. And a key part of that is being able to make things that are very difficult easier. And so actually, as we form these training hubs, as we form these local education providers within the ICSs, as we form those teams, I'd like you to think about how you're best going to support your workforce. And I'm technology agnostic. It doesn't really matter what that technology is, but it needs to be a technology that's going to make things easier for me. So when Niraj and I were spitballing about half an hour ago, kind of just talking about the issues and the challenges, how amazing would it be, for example, for me to, when I'm sitting there at 7 o'clock in my clinic and I'm just trying to get something done, to just call a number that's saved on my phone that's going to ask me some questions and say, what have you learned today? What was a good case that you came across? And what did you take out of it? And I'm talking back to that and it's populating my portfolio. That is a far more effective way of capturing that learning. And we need to do better in terms of capturing our learning throughout postgraduate learning pathways, through undergraduate learning pathways, and also for people that are continuing professional development. And I believe that should be part of an ICS strategy in terms of workforce development.
That's great, Hatim. I think for what you just said about your Friday, the way you describe that Friday, I think as if there's technologists in the room, one of the principles that we've built, what we've built, has been around meeting the clinician or the practitioner where they are. And that's a big part of a design decision, to really think about how much AI is good enough and how much of that is about the human. And for us, putting the human at the center of AI is a big mantra we follow. And that means that we actually thrive to find the clinician where they are. And the story you painted around what happens with the appraisal process, and just the fact that you're learning, but you don't have the time to capture that, or you're not in a place to really open up something and journal something. And that's where AI's powers really kick in, helping you make sense of your day, make meaning out of your day, and capture that in a place that's your personal notebook, which can be your breadcrumbed journey through learning throughout the year. And that's really where we are looking at technology, and we're looking at the solution set that we have, and our potential collaboration of thinking about, hey, let's explore that specifically for the population. Let's explore that specifically for a certain type of a provider or a practitioner and the challenges they face. Because the other thing that I think you've noted really well is just how specific are these problems to GPs versus nurses? What are some of these patterns in your work, as you shared some of your journey with the tech and the AI that you've implemented? I think you've seen, radiology has used image AI quite heavily, and then you've got admin teams, non-clinical teams using AI for other admin work. What has been your experience working with different flavors of AI with different specialties and different practitioners?
So I think what I said to you was there was something around the delivering education and training part that I wanted to come around to and say, the AI roadmap is really interesting because it helps shape the conversation that we have with practitioners. It helps shape the conversation that we have with colleges. Because the difficulty is if you don't see the type of technology that existing and you're using it, it's very hard to kind of make that cognitive, go through that cognitive process where you're quite supportive of a technology or you see the benefit it's having. An example being, when I talk about diagnostics being such a key area, well, how do you break that down? Where is the efficiency saving? Where is the time saving in that process? We had lots of conversations off the back of the AI roadmap to say to the British Institute of Radiology and the Royal College of Radiologists, well, look, we know this is an area where technology is coming in. What we don't know is actually how much impact is it having on your workforce, and how much impact is it having on the way that people work. So what can we do to better understand that problem, build some case studies, and also actually build some education and training that's going to be relevant to them as individuals. But if I think about my own practice, and I wouldn't say we use AI rapidly, but saying that, we're reflecting on kind of the role of certain tools like the Q risk score, which is a score for you use for high cholesterol and identifies that whether you should prescribe a statin or not. In some ways, that's a statistical tool, which is not too different behind the kind of the theory of how AI and kind of data-driven healthcare will be going down. But we do have technologies like robotic process automation that make a huge difference to the way we can work. So for example, it's not something my practice has explored, but I know of practices locally that are using robotic process automation to deal with docmans, which is kind of the letters that come through within your inbox. They're using robotic process automation to filter through normal blood results so that you can focus on the abnormal blood results. They're using robotic process automation to tackle issues around engaging patients with their asthma and COPD and their chronic management and get their information in terms of meeting their targets and sort of supporting them with their chronic disease management. So there are certain technologies that can be really helpful and can be used. It's about kind of creating a culture within an organization to one, be open to innovation and open to risk and open to say, look, we're not doing things very well at the moment anyway. Why don't we just try something out and see if it makes a difference? And if it doesn't make a difference, that's fine. We'll kind of revisit this in a year's time and then think about it again. You need to say, you need to create headspace, and I think that's the biggest challenge. So I've done a lot of work with our primary care network to look at how we can use AI to tackle things like our triage hub. So one of the things that we're doing is trying to bring all our 5 surgeries together and allow patients to access all of the surgeries at once to kind of better allow our kind of management of patient care and triage across all 5 surgeries. And that's really great if it works well for patients, but actually, that's a real opportunity to look at that process from start to finish, and to look at how AI might help with some of that triage, and might say, actually, this person needs to go and see the GP, but this person needs to go see the pharmacist, and this person needs to go see the practice nurse, and actually, this person can wait 2 weeks, whereas this person needs to be seen right away. So there are solutions that exist in all of these spaces. It's about creating a headspace to give them a go, pilot them, create that real-world evaluation so you've got a level of evidence, and then move things on from there. And that's difficult to do, but I think you need to give people time, you need to invest in people and actually say, look, you're not going to be clinical for a couple of days a week because you are going to be driving this solution through. And you also need to create the right infrastructure and ecosystem around it. So, one of the biggest challenges that our primary care network has had is just integrating EMIS across all 5 practices, which is the electronic healthcare record. It's not been easy. It's been really, really difficult. But actually, once we've got there, you've then unlocked a tool towards achieving what you want to achieve next in terms of building that AI triage for patient care.
It's very, very insightful. Thanks to the team. I'm going to use maybe what we have about 5 minutes or so. Henry?
We've got about enough time for 2 questions.
Excellent. So if there's any questions, yes, we have.
Hello. Hey, thank you. That was super, super interesting. So thanks for both of your insights. I'm keen just to push a little bit on kind of AI as a buzzword, I guess, in that I feel like we're very keen, and I've been in investor meetings where they've said we're not investing in anything which isn't AI, for example. And I think that there's a lot of enthusiasm for pushing forward things which are AI-enabled or whatever. And you touched on it there with talking about kind of robotic processing automation, which is, I guess, not technically AI, but still super helpful. To what extent are we kind of falling into a bit of a trap of trying to run before we can walk by kind of encouraging loads of AI in healthcare before we have kind of the fundamentals in place, and how might we mitigate that?
So I don't know if you've seen that. Have you seen that Gartner chart, which basically talks about kind of technology? Well, it talks about various things, but basically it kind of gives you an overview of the hype stage, and then you go through that stage where you go into grief basically, because actually it's not achieving the hype. And so I think it's a really valid point, and the way I think about it is, what's the problem? What is the thing that you're trying to solve? And then therefore, what is the right solution to help solve that problem? And you're right, infrastructurally, in many places we're not ready. And this is why when I talk about ICS maturity, a lot of that ICS maturity needs to be building the shared data care, building the shared data care record or the secure data environments, and focusing your time on actually getting data ready and data mature so that you can then actually make proper decisions with data for your population. That's where the focus needs to be for ICSs. It's not on kind of leveraging and using clever AI technologies at this stage, apart from for where there are very simple problems that could be solved either by robotic process automation, which is not AI really, or actually some AI and data-driven solutions in that space. So actually what I would say is identify the problem, something that we do at Kent, Surrey, Sussex. So if you're within the region, particularly for Surrey, we have a health tech accelerator there where we say, if you come to us with a problem, we'll then do a horizon scan to say, what actually exists in this space? Is there something that can help solve that problem? Then we'll do the real world evaluation as you try and pilot that solution once we've done the horizon scan. And then you can decide, then we can all decide, is this the right thing to do or was this not the right thing to do? That is the process that you need to follow. It's basically QI methodology. If you don't, ultimately that's what improves patient care. We know it does. We've been doing it for years and years. And if you follow that process, it's really helpful. Similarly, if you're not in Kent, Surrey, Sussex, the AI Skunkworks team at NHSAI Lab do a very similar thing. If you go to them and say, this is my problem, they'll say to you, no, actually, AI is not going to work for that. This is not the road you want to go down. Or they might say, actually, yeah, maybe AI could work for that, and let's think about how we enable it.
Got time for one quick fire question, if anyone's got one.
If there's any practitioners in the room that learned something, drop us a note, we'll give you credit.
Excellent. Let's give a big round of applause then to Niraj and Hatim.